Hi, you're watching DNA Today, a multi-award winning genetics podcast where we explore everything to do with genetics, from CRISPR to rare diseases to new research. We have won the Science and Medicine Podcast Award for many years now. We have hundreds of episodes, and we really hope you enjoy these conversations where we dive into so many genetic concepts. I'm Kira Deneen, a certified genetic counselor and your host. With millions of people now taking GLP-1 antagonists like Ozempic and Wegovy, I was curious to learn if there are known genetic mutations that predispose people to have serious side effects from these medications. So essentially exploring the pharmacogenomic aspects of Ozempic and Wegovy. To answer my questions, I'm joined by Dr. Josiah Allen, who is a brilliant mind, and he's been at the forefront of understanding how our DNA affects our medications since his groundbreaking work at the Mayo Clinic. And that's where he actually helped to develop the GeneSight test, which I was just saying before we hit the record button, that's the first pharmacogenomic test I had heard of. So it's a little pinch me moment. I actually get to talk to one of the people that helped develop this test. So that's very cool, fangirling. And as a founding employee and the first medical science liaison at Assurex Health, he helped GeneSight become one of the fastest growing molecular diagnostic tests in history. So adding to the fangirling. So Josiah, thank you so much for coming on and getting into all the pharmacogenomics with me.
Kira, thanks so much for having me.
So before we get into the weeds, as I do on this show, can you set the scene a little bit in terms of what pharmacogenomics is? Because I've alluded to it, but let's just make sure that everybody's on the same page listening.
Yeah, absolutely. So pharmacogenomics, in a nutshell, is the genetics of medication response. So looking at how our genetics influences how we respond to medications. And as you mentioned, I'm a pharmacist by training, by background. And so as a pharmacist, when I think about medications, there's sort of two pieces that I think about. The first is what the body does to the drug, and the second is what the drug does to the body. So in the first case, we're thinking about how is the drug absorbed? How does it move around to the different tissues in our bodies? How does it get metabolized? And then how ultimately does it get excreted from our body, get out of our body? And then the second case, we're thinking about once the drug is in your body, what is it doing to have its clinical effect, the reason that we're prescribing it? So pharmacogenomics looks at both aspects of that.
And often in these reports you see, because I've seen a lot of sample reports, and I've actually done one myself, I'm realizing now too, that it gives information like what would the metabolism of this drug be? And is that a drug that even kind of works with that person's genetics of at least what we know about so far? I mean, this is a rapidly growing area. I think in the last 5-10 years, I mean, it's changed so much in terms of how many data points we have in terms of understanding the variants that exist and then how that affects how the medication is being absorbed, how it actually helps the body, hurts the body. So it's just a very fascinating area of genomics that is growing so much. And with your work at the Mayo Clinic and then Assurex Health, how did that help you understand like this intersection between clinical genomics and looking at all of this pharmacogenomics?
Yeah, again, I think it's really interesting because oftentimes we're really focused in on the particulars of the medication, how it's absorbed, how it's metabolized, how it's excreted. And that's really where most of the research has been, because it's really easy to like take a blood sample and figure out how much drug does someone have in their body at a given point in time. It's a lot harder to figure out what is it doing when it gets there, especially when we think about, most of my work has been in mental health. It's kind of frowned upon to like take samples of people's brains when they're living and
We should try to avoid
right.
it when we can.
We should try to avoid that. So it's really hard to do that type of research and really understand what the drug is doing up there and genetic factors that influence its response. So that piece has always been more difficult. And so this piece of clinical genomics is also really difficult because by definition, most patients with genetic conditions, they're by definition rare, right? They're not super common in most cases. And so they often don't end up being people who are part of the original clinical trials that end up getting the drug approved. And in many cases, they specifically get excluded from those studies because they're trying to figure out how is this drug going to work in the quote unquote the average person, right? But by definition, patients with genetic conditions aren't going to fit that mold, right?
That's a very good point.
Yeah, so oftentimes it's a really understudied area because they just aren't represented in their original clinical trials.
Yeah, any kind of outliers is hard to incorporate in data, and sometimes those outliers get left out of the data even if they originally are in it, depending on the study and the nature of that study. And when I was going through your work, at least some of like presentations you've given and a poster presentation, which we'll link to a bunch of things in the show notes at dnatoday.com, one of the things I was most surprised with is this statistic. Over 1/3 of the ACMG secondary findings, technically V3.2 for people that are really paying attention to that. So over 1/3 of these genes on this list for secondary findings have pharmacogenomic implications. That's a lot of them. And ones, just the ones that we're aware of. I can't imagine how long that list will become in the coming years. So break this down a little bit further, because I sort of understand this, but can you explain it more and why this is not talked about? Why is it that the only person I've personally come across talking about it is you, Josiah?
Yeah, absolutely. So first of all, let's talk about the ACMG list. So the American College of Medical Genetics. One of the big thorny questions in genetics is always when you have somebody who has a particular genetic variant, what level of evidence is sufficient that we need to have in order to sort of take action on that genetic variant? That's one of the hardest questions, because we'll see somebody and they have a particular variant, and maybe we have some data but not a ton of data, and there's always that question of when do we kind of pull the trigger and start treating that as something that's clinically meaningful and clinically significant. And our sort of a related question then is, when we do sort of whole genome sequencing or large sequencing of data and we see variants, particularly variants that we know have action, when do we take action and report those back to the patient so that they can take action? Particularly if this is part of a research study or the testing is being done for some very specific reason, and then we happen to sort of incidentally find other information, when is it ethical or unethical to report or not report those kinds of things? And so that's why the ACMG created this secondary findings list. These are the genes that the ACMG has decided to say, like, it's unethical not to report this information to a patient if we find it, because they are genes that have a lot of strong evidence for their impact, and they're also genes where the conditions that they cause are things that we can take action on. So think we can increase screening. There may be medications we can prescribe. There are different actions that we can take that can help reduce that patient's risk or burden of disease by knowing that information. So that's the list. That's the ACMG list. There's about 81 genes on that list. And so these are kind of the core set of the genes that we really know are super important. As you can imagine, a lot of these genes are things like hereditary cancer syndrome, so we can increase screening. So BRCA is on there. Marfan syndrome is on there as one where we can monitor patients for conditions or for symptoms of Marfan syndrome and things like that. So one of the things as a pharmacist I'm really interested in, what drugs, for patients who test positive for one of these conditions, what are drugs that we should be treating them with? And what drugs should we be avoiding for those patients? We talk about in medicine, there's kind of a famous saying, the dose makes the poison. And the idea here is that everything is a poison. It's just a question of dose. Even water, you're just taking a big swig of a giant bottle of water.
Yes.
Even water is toxic at high doses, right? If you're drinking gallons of water a day, you can actually die from that. So everything is a poison. It's a question of dose. And like we were mentioning earlier, when patients aren't part of clinical trials, especially those dose finding trials, we don't necessarily know. We know what the dose is that's safe for the average person, but for a patient with a genetic condition, there are things that are in their body that are perturbed. There are systems that are not functioning the way that we would expect them to. And as a result, medications can be more toxic for those individuals. And so we need to know that. And it's a part of good management of care for those individuals to know this information and make sure that patients are taking care of that information.
Especially with, like you mentioned, Marfan syndrome, one of the symptoms I think about first with that is cardiac problems, heart problems. And you wouldn't want to have any kind of medication, I'm thinking, that is going to affect any kind of cardiovascular issue. So that seems to be, oh, that makes sense. But I didn't think about it in that context of we need to make sure that's listed so that anytime this person with Marfan syndrome is prescribed something, that person prescribing is taking into account they have Marfan. Does that include any cardiac findings? And tailoring that care, because it's so horrific when we look at certain statistics of deaths, especially in the United States, caused by the wrong medication or wrong dosage, and the deaths being caused by that. So it makes sense coming from the genetic standpoint. It's like, well, what can we do to make sure that we're looking through all of this and understanding? It's surprising we're not at a point where, I mean, as a genetic counselor, I don't prescribe anything. So maybe it's just because I'm not in a prescribing area, but I would think this would be a little bit more common knowledge and a topic talked about more because of that factor of making sure that people with genetic conditions aren't taking certain medications.
Yeah, I think Marfan syndrome is a great example. So Marfan syndrome is at heart, it's a connective tissue issue, right? So the fibrillin gene is the one that's affected in Marfan syndrome. And so fibrillin is one of the chemicals in your body that kind of helps keep your tissues and your ligaments and things like that, keep them together. And patients with Marfan syndrome tend to have looser joints. They just tend to be looser in terms of their connective tissue. And so one big concern that they have is that their aorta, so their main blood vessel, can rupture because the tissue there is not as strong as it should be. We have a class of medications, a class of antibiotics called fluoroquinolones. Levaquin is one that people are pretty familiar with, or levofloxacin is the name of it. And those are actually associated with tendon rupture. So there is a rare side effect with those medications where your tendons can actually rupture. My dad actually had this. He had Levaquin and he had like his Achilles tendon ruptured after that.
That
And
sounds
so that's a
incredibly painful. The Achilles
oh,
tendon. Oh my
super
goodness.
painful. And so you can imagine giving that to a patient with Marfan syndrome who already has weak connective tissue is not a great idea. So these fluoroquinolone antibiotics are actually contraindicated in patients with Marfan syndrome. But the trouble then is, if you've got a patient with Marfan syndrome who gets a nasty infection and ends up in the hospital, how does that hospitalist know that information and make sure not to give them the fluoroquinolone antibiotic and give them something else to treat that infection? That's setting us up for problems if we don't know this information.
Yeah, and lawsuits, right? So it's like hospitals and these big organizations, legally, they have to think about things like that. The first thing that should come to mind is just protecting patients, right? Patient safety. But in terms of hospitals and everybody's bottom line, they have to look at that of how can we prevent lawsuits? How can we have better protocols in place? And if I feel like anytime someone's prescribing something, it's like, do they have any genetic variants that contraindicate that medication is the way I would phrase it as a
Hmm.
non-pharmacist.
Yep.
So, and we talked, I prefaced at the beginning that we're going to be talking about these GLP-1 antagonists, better known as Ozempic, Wegovy. And that's how we originally connected. Talking about, I mean, in the past, 18, 24 months, I would say, it's January 2025 now. It's just been all over the news. I have certain friends, family that I know that have been taking this medication or interested in taking it. People are talking about it. It's on South Park. It's just everywhere, right? All the talk shows. So it's just, for me, it was just like, this seems to be quite a serious drug with very serious potential side effects with it, especially for people that are on it for a long time, of just what I've learned in the general media. And so I'm like, is there genetic variants that are contraindicated for this Ozempic, Wegovy? I'm aware of at least one gene. Do we say RET gene or RET?
I say Rhett.
RET.
Yeah.
Okay, that's what I was thinking, but I was like, I got to make sure I have Josiah tell me the right way. So why this gene? I guess there's probably a lot, but you've been a little bit more focused on the RET gene.
Yeah. Well, let me just tell you a patient story. We can maybe start off by just
Yeah,
kind of
let's
talking about
do
a
it.
patient. So we actually had a patient here at my hospital who came in for genetic counseling. So she came in and saw our genetic counselors because she had a family history of cancer. And so she was interested in just getting additional testing to learn more about that. So she got genetic testing and she had a mutation in this, or a pathogenic variant in this gene called RET. RET, I forget what it stands for officially.
We'll put it in the show notes.
Yeah, there you
Yeah.
go. It's a gene that's associated with a hereditary cancer syndrome. So it's involved in cell signaling and cell growth and differentiation. So it's one of those genes in the pathways. So like you get a paper cut, you've got some cut in your skin. There's signals that your body sends to the skin cells around that cut to say grow more so that you can fill that cut and heal the skin cell. And so there's all these signaling pathways that tell our bodies to start producing more cells, to stop producing more cells. And these are some of the systems that go wrong in cancer syndromes. When those systems get broken, cells start to grow and develop and differentiate too quickly and don't really have the brakes to stop and say stop growing, and that's how we get cancer and tumors and things like that. Pathogenic variants in RET can lead to problems in the cell signaling pathway, and RET is particularly expressed in our endocrine system. So our glands, our thyroids, our adrenal glands, some of the different tissues like that. And that's where it's sometimes preferentially expressed. And so if you have a pathogenic variant in RET, you're much more susceptible to thyroid cancers, adrenal cancers, which are called pheochromocytomas, and conditions like that. So that's kind of the connection between RET and cancer.
And then for this, then, like, for what the hereditary cancer syndrome would be called for people that have a mutation or pathogenic variant in the RET gene, would that be like the MEN1, MEN2? Am I getting that
You got
right?
it.
I'm trying to remember
Yep.
from boards. Okay.
Yep. So breaking it down. So MEN2, it's multiple endocrine neoplasia. So multiple systems in your endocrine system, multiple glands in your endocrine system, and neoplasia is cancer. So multiple cancer syndromes related to your endocrine system. So that's
Gotcha. Now the genetic counselors are like, oh, it was that slide. Got it.
There you go. Yep. So MEN2 is one of those conditions that causes. Now, fun fact about our GLP-1 agonists, or not so fun fact, is they also have an increased risk of thyroid cancer.
Interesting. So the Wegovy, Ozempic, if people are taking that, have been on that, they have that increased risk for the cancer.
Exactly. So if you listen to the Ozempic ad when it comes on, and when the guy talks really, really fast about all the side effects, one of the things that he says is, you don't take this medication if you have a diagnosis of multiple endocrine neoplasia because of the increased risk for thyroid cancer. The GLP-1 agonists, so the way that these drugs work is they basically help facilitate a feeling of satiety or fullness. So when we eat, there's like signals that our stomach sends to our brain that says, I'm full, stop eating. And GLP-1 agonists work by kind of sending that signal to our brain faster. So we feel fuller, faster, and for longer by taking these medications. But they also work by signaling in our thyroid system. And so there is this increased risk where if we stimulate that receptor too much, we can cause thyroid cancer. This was really shown to be like kind of definitively true in some of the original animal studies for these drugs. But humans are different enough in this respect from like rats that the signal wasn't as strong, where it was like everybody who takes this drug is going to get cancer kind of a thing. But it did pop as a safety signal in the original FDA trials, where they actually have a black box warning. So the highest level of warning for a drug is the black box warning on the FDA package insert for the drug that says there is an increased risk of thyroid cancer in patients, and do not take it if you have MEN2A.
So you don't want to have then, if you are born with a genetic that you have an increased risk for thyroid cancer because of a genetic variant, such as one in RET, we don't want to then add even more to that risk, where then you're at, let's say, extreme risk of thyroid cancer, or something even higher. We don't want to compound the risk.
Exactly. It's like a double whammy, right? We want both of those things happen at once. And so our patient, going back to our patient,
Yes.
we were reviewing this patient's chart and saw the genetic counseling note in there. And interestingly, so the way that this patient got to us on the pharmacy side had nothing to do with her RET mutation. She actually sort of, for completely different reasons, got testing to actually help prescribe her antidepressants better. So she had some depression and anxiety, and they were getting pharmacogenomic testing to help prescribe that. And so from a first glance at her pharmacogenomic results, nothing really popped for us. There was nothing in her chart, nothing in her med list that made us really concerned. Everything looked good from a pharmacogenomic gene perspective, the genes that we typically look at.
Was there anything helpful in there? Like, it's good to know, oh, there's no drugs being flagged that that patient should not be prescribed. But what about the flip side, especially for someone that maybe hasn't been prescribed an antidepressant before? Can it, in this case at least, was it helpful to say, well, maybe we'll start with this one because this one seems to be, maybe it's going to be better for this person based on their genetics? Or was it kind of like, both ways? We didn't have any green or red flags.
Nothing much. There was a couple of drugs where we'd say, hey, maybe you dose it a little bit lower than you normally would. If the normal dose is 10, maybe you start at 5 and maybe go a little slower with the dosing, but nothing sort of earth shattering.
Okay.
That we would say, hold the phone, let's stop, let's pump the brakes here. And so that's kind of at first glance, nothing too exciting that kind of popped for this patient. Now, if you had somebody who was maybe going, one step above, they might dig into this further, and they might read that genetic counseling note and look at that RET variant and maybe do some Google searching and hitting some of our different resources that exist. And so there's a few different resources that clinically we use frequently. One, as a genetic counselor, I'm sure you're super familiar with gene reviews, which
Yeah.
is, yep. It's like the Bible for genetic conditions for clinicians, I think. And it's a great resource. And actually, there is a section in gene reviews for some of the different conditions that are in there called medications and circumstances to avoid, where they actually talk about environmental factors, which include medications that can influence or be a risk factor for a patient with a given condition. So if you read the description for the Rett gene, they talk about a couple of genes. And it's mostly related to the pheochromocytoma, the adrenal tissue. So you don't want to give patients drugs that are also going to affect their adrenaline or their adrenal system because that could interfere with screening for those tumors. It might give a false positive in some of those screenings that we use. But nothing about the drugs that we're talking about, like our GLP-1 agonists. The other resource that we frequently use is more on the pharmacogenomic side. It's a resource called PharmGKB. And so this is a big knowledge base where they kind of scrape all of the published literature in PubMed and other areas and suck it into the database to kind of make sort of a compendium of pharmacogenomic knowledge. And if you go to the Rett page in PharmGKB, you'll see a few things about some cancers that are known to be like better or worse, but more or less likely to work in a patient with the Rett mutation. But again, nothing about our GLP-1 agonists. The third place you can go and look is the FDA themselves. And so the FDA actually has a website, and it's called the Table of Pharmacogenomic Biomarkers in Drug Labeling. And so they have a giant table of all of the different drugs that have any even sort of mention of a gene in there. And sometimes it's hey, we looked at it in this gene and it's no big deal, go ahead and prescribe it. And that'll even make the list. But Rett for GLP-1 agonists doesn't even appear on that list. So the question is, so even if you're going one step above and you're checking these different resources, you still would not find the information that we've been talking about so far.
Do you think that's because these are newer drugs, or this is just one of many cases where medications are not listed as a contraindication for genetic mutations?
I think it's a problem with our systems. So the way that all of those systems really work there's just too much information. So they're all automated systems, right? So they are looking for gene names and gene symbols, so RET, for example, right? But when you read the GLP-1 agonist package insert, it actually never mentions the Rett gene at all. It only mentions multiple endocrine neoplasia.
So you have to, as a human, put those together.
Exactly. So you have to put it together and say, if you have a Rett variant, you have multiple endocrine neoplasia. If you have multiple endocrine neoplasia, you shouldn't get a GLP-1 agonist. So you really have to go above and beyond. Now, fortunately, here we have some people who are absolutely 2 steps, 3 steps above the average person. And so I had a fantastic resident who was working with me at the time, who was reviewing this patient's chart. She's the one that actually found this, made the connection in her brain. I saw Rett, saw multiple endocrine neoplasia, and connected it. This lady was taking a GLP-1 agonist. She had type 2 diabetes, and so she was taking it to help with her diabetes and was therefore at an increased risk. So we were able to intervene. We contacted her primary care provider, said, we got to stop. We got to switch her to a different diabetes medication that doesn't carry this risk. And so we were able to intervene. But I think the shocking thing was, it was also an issue of kind of getting lost in the cracks, right? Like the oncologist who's kind of looking over her case wasn't thinking about her diabetes, and her primary care provider wasn't thinking about her genetics results because it was sort of out of scope for both of them. So there was nobody who was kind of looking at the intersection of the two. And that's the problem.
And we see that so much, unfortunately, where to have a provider that's looking at the whole picture is so important because of examples like this, where if you have your oncologist, they're only really usually thinking about your cancer risk, your surveillance, your management, whatever spot you are at. And they're not, necessarily looking at the details of how your diabetes is being managed. It's like we need in our healthcare system almost like your healthcare provider, like point person that then talks to all your other experts to make sure everything is coinciding the way it should be. And I guess sometimes GPs can be that, but sometimes not, especially when it comes to something like this. It was missed by so many and caught by a resident, which is just phenomenal. Shout out to that resident, because that is really quite a save. And if it wasn't for that resident, the patient would probably still be on the medication or had continued. I don't know how long ago this was, but probably pretty recent because this drug has
Yeah.
only been available so long.
Yeah, exactly. Yeah, no, I think you're exactly right. I mean, this is a problem where things fall through the cracks, and this is where problems happen in healthcare. So one of the things that I'm super passionate about is reasons like stories like this is getting pharmacists more involved in clinical genomics. So we've started to develop an expertise in pharmacogenomics and really thinking about drug metabolism and things like that. But I think we really need to start expanding our vision, expanding our scope of what we consider to be in scope for a pharmacogenomics pharmacist. And so this is something that I'm super passionate about right now. We are actually in the process of going to the Board of Pharmacy Specialties, so the board that kind of oversees all of pharmacy and the different specialties within pharmacy. And we are advocating right now for a pharmacogenomics board certification so that we can have board certified genomic pharmacists out there who can do this. I'm pushing hard that stuff like clinical genomics needs to be on those board exams, and information that a genomics expertise pharmacist should be aware of so that they can be the one who's catching this stuff. If we go back to that example of the patient with Marfan syndrome, we can't have a medical geneticist following every single patient around, checking on every single patient who gets hospitalized. There's just not enough medical geneticists, just not enough genetic counselors to be able to offer that kind of care to our patients, even though they need it. So what we need are smart systems that help to identify this stuff. So this is some of the stuff that we're doing at my health system at St. Elizabeth Healthcare, is we're actually building systems in our EHR and in our electronic health record that can flag these medications for patients. So now if you come to St. Elizabeth, if you are that patient who had a RET mutation and came in and were about to get prescribed a GLP-1 agonist by your primary care provider for your diabetes, they're actually going to get a pop-up that says, nope, this lady has a RET mutation. She should not be getting this medication. Try again, pick a different medication. Here's some drugs you can select from instead. So we're helping our primary care providers get smarter about genetics, become the genetics expert through clinical decision support, not through hiring more medical geneticists and genetic counselors, because that's just not sustainable.
No, it's not. And I think it's so important that genetics needs to be taught to really all healthcare providers, I would say, varying levels. And I think pharmacists have been in that area of on the list of who I think should get the most education on this because of these types of examples. And so that when a provider does prescribe a medication and that pharmacist is going to fill that prescription, or if the pharmacist is the one making the prescription, like whatever in that they are in that process, to be able to interview and say, hey, hold on, I'm looking at their diagnoses and this is contraindicated because of this. But that's also not going to be easier said than done because we have so many pharmacists that have already been working in the field that, and some have been grandfathered in terms
Mhm.
of, having that medical level of a degree, because some, when they were going to school, it was what the master's was the terminal degree decades ago. So it's just a lot. It's hard to catch them up on where we are today, let alone where we're going to be tomorrow and in the future. And so taking advantage of those tools like pop-ups in EHRs, EMRs is so helpful. And like that's an example of we're not taking away jobs from genetic counselors. We've got enough going on. We can't get hired to be able to do all of this. There's not enough genetic counselors, not only in the US, but other countries even more so. So it's so helpful to be able to do that. And I would expect we're just going to learn more and more genetic conditions and certain variants that are contraindicated for the Ozempic, Wegovy, as well as a bunch of other medications. But for these being medications that so many people are getting, I worry about, the future of that. And we're unfortunately probably going to discover some things because people have symptoms. And all of a sudden there's this influx of a certain type of symptom. We look into it. Oh, well, most of these people have this genetic variant.
Exactly. I mean, ultimately, I think this is what we're going for. This is precision medicine. This is preventative medicine, where we can know a patient's risk factors and use that information to choose or not choose to expose them to certain things that could cause them problems. So another example of a patient that we just saw the other day was a patient who had a genetic variant in a gene that's associated with an increased risk of melanoma. And so it was a melanoma condition, and we actually have some medications that cause an increased it makes your skin more sensitive to sunburn. So one of these is hydrochlorothiazide, which is a really common blood pressure medication. It's one of the most commonly prescribed medications in the United States. And it increases your risk of sunburn and skin damage, which is going to compound on top of your genetic risk. So knowing this information, we don't have to wait for someone to develop skin cancer and then look back and say, ah, shucks, we shouldn't have prescribed them hydrochlorothiazide. We can move ahead of this, try to get ahead of these issues and be preventative and think about patients' risk. And maybe that patient still might need to go on hydrochlorothiazide because it's going to be the best drug for their blood pressure. But let's go into it eyes open and making sure that everybody involved, patient, provider, pharmacists, are aware of the risk and are taking steps to mitigate that risk however we need to, increase skin cancer screenings, things like that, whatever we need to do.
Not having them bake in the sun for a week while they're
Right.
on the drug, something like that, right? It's like, oh,
Exactly.
You need to stay covered up. If you're going to the beach, you need to wear one of those very, very stylish rash guard,
Yep.
shirts that go all the way full long sleeve
By
shirt.
the SPF 10,000.
Exactly, right? Yeah. So I think there's certain things that, with so many medications and from my limited exposure working with pregnant patients, it becomes down to this risk reward. Like, okay, well, there are some risks of being on this medication or some side effects, but we really need it because of these reasons. And that's why your job is so tricky too, because it's not always this drug is good for this person. As you said, this is precision medicine at its crux because it's always going to differ. Like if someone should be on, if they're pregnant, should they be on certain medications to help with their mental health? Sometimes that's yes, sometimes it's no. It's the same drug, but it depends on how much their mental health symptoms are impacting them and impacting potentially the pregnancy. So nothing is straightforward. You live in the area of gray. I mean, it's not black or white.
Yeah, totally agree.
Yeah. Well, Josiah, thank you so much for coming on. I mean, this is something that is so interesting to me. And, we're going to keep we have a few more episodes for listeners lined up for 2025 about pharmacogenomics because we're here. It's happening. We started the show almost 13 years ago and it'd kind of be a mention here or there. Some days now we're doing this and it's really helpful that it should be part of the process to be looking at all of this. So thank you for, explaining all of this to us, but even more so what you're doing in the field to push pharmacogenomics forward. And, hopefully I'm getting an update from you like, yes, this is now something that's more established in our field in terms of different practice guidelines, having that, what did you mention in terms of a certain field, a career title in pharmacogenomics that you're trying to pass?
Yeah, board certification for pharmacists. Yep.
Yeah. So if there's we'll include some information in the show notes about that as well. But Josiah, thank you so much. This was just riveting.
Absolutely. Thanks for having me.
Thanks for watching DNA Today. To access all of our episodes, head over to dnatoday.com. We also have a lot of bonus content on there that you can enjoy. If you have any questions, comments, suggestions, guest pitches, you name it, send them in to info@dnatoday.com. We'd also really appreciate if you could take a moment to rate and review the podcast on Apple, Spotify, wherever you listen to the show. It really helps more nerds like yourself find the show. Also, if you like giveaways and other ways to connect with us, I recommend following us on social. We're at DNA Today Podcast. We also have a Patreon if you want to be the most level involved in the show. That's also at DNA Today Podcast. Thank you so much for listening and watching. Join us next time to learn and discover new advances in the world of genetics.